Sengupta, what barriers you want to break? Mike?
I think I'm audible now. Very good morning, everybody. And so, we'll, so what do you think is the biggest barrier in management of neovascular AMD today?
System, but to my knowledge, two only. One is all of them don't respond, and secondly is the durability, because these two things put off most of the patients.
Right. So the biggest barrier really is giving injection after injection and still not getting desired responses. So before I go to my talk, I'll perhaps do a couple of comments on the previous lectures. So Dr. Luthra presented on and we had a lot of discussion on whether you can actually move from one to the other and biosimilars. So though Indian companies are coming up with biosimilars and there are so many in the market, we are not seeing enough rigor in terms of clinical trials, and companies are not doing trials because the DCGI does not demand those, isn't it? But I think as physicians we need to demand clinical trials and only then use those drugs in practice, because if you say it works, it may work, but from a head-to-head basis, have you actually seen in the real world whether it's actually working or not? Because we are going to see a huge barrage of biosimilars, and how do you decide? And so the Indian companies need to understand that scientific rigor is very important, and we as clinicians today want to see data and trials. So we are seeing trials in pilocarpine, we are seeing, as in the Indian pilocarpine, we are seeing trials with Indian atropine. We are also seeing clinical trials with ranibizumab. That's only one company has done it, but all of the others need to do it. This, the second thing about fluid and leaving behind fluid, I think, is tolerating fluid would be the right word, and not leaving behind fluid. So the concept was, what do you do when you're giving multiple injections and the fluid is not going away? There's nothing much you can do.
This is a very good word.
So you need to tolerate it. But then these concepts are getting outdated with brolucizumab now, or with the stronger drugs, because tolerating fluid with brolucizumab is not really okay.
That's
so,
what I said, Sengupta, because I was disagreeing with
exactly. So
that is a defeat of molecules. Suppose I am doing A, B molecule and fluid is there, vision is also maintained. Now inject brolucizumab, this fluid goes away. So that means these are defeat of the drug, not the...
Right. So I'll show you a couple of my cases, and so I'll quickly share some clinical trials, and then how do I actually import all of that into real practice is what we'll discuss, and hopefully we'll break some barriers, and so some necessary disclaimers. And so we know that neovascular AMD is much on the rise now, and this is the very large study done at Shankar Nethralaya which showed late AMD, that is neovascular AMD, is affecting about 2.5 to 3% of the aged population, and the absolute numbers are relatively high. And so, Dr. Luthra also mentioned about the Luminous study. So if you give loading doses, the vision actually improves. So there are 54 letters, really means 6/24 vision. And if you give loading doses, the vision goes to about 618, sometimes 612. If you don't do loading doses and you give the same number of injections over 1 year, you do PR and you say give 1 injection every 2 months, the patient will drop vision. Right? So if you give 6 injections but with the loading dose and space it out, patients will gain vision. If you give 6 injections but don't do the loading dose, patients will lose vision. And so, the unmet need from a physician's point of view, so this is the PAT survey which was done by the ASRS, and it happens every couple of years, clearly shows that physicians also want reduced treatment burden. Nobody wants to keep injecting again and again. And when you actually ask patients and the physicians, so patients prefer fewer shots, even if they lose some vision. That's I think very profound, right? Patients are okay with losing perhaps 1 line of vision, but they don't want that many injections, and we need to cater to that. And physicians, of course, also want fewer shots, and the commonest option that people chose was combination of B and C. Patients also want fewer injections, doctors also want fewer injections, but at the cost of losing vision, so that's really defeating the purpose. This was in 2018, before brolucizumab came into the picture. So the ongoing challenge really, or the real barrier, is to maintain treatment efficacy while reducing clinic visits, as well as the number of injections, and thereby the cost. So, so as we've been talking about, so, why does brolucizumab reduce the number of injections? Is because it's a really small agent. So it's a single chain antibody fragment. So we know the FAB fragment, the FC fragment, and there is, something which is sitting like a cherry on the cake on the FC fragment, which is actually the single chain antibody fragment, and that is, so scientists have managed to just about isolate the active part of the whole jigsaw and give it to us in a packaged form, that is brolucizumab. So it's a 26 kilodalton, it's a really small molecule. So you can pack 6 milligram of drug into that 0.05 allowance that we have, whereas aflibercept can pack 2 milligram and ranibizumab can pack 0.5 milligram, right? So there's a huge dose advantage there. So, so Dr. Chronopoulos has told a little bit about the Hawk and Harrier. It was these, these were global trials, and India was actually part of the Harrier trial group. There were some centers in India which have actually recruited about 40 patients in the Harrier trials. So the key inclusion quickly was, of course, there was active neovascular membrane. And this is what was done, and I think this is what, if we can actually adopt this in clinical practice, it's not very difficult. Let's look at what was done. Was a loading dose of monthly for 3 months was given, irrespective of how the OCT looks like. Right? So many of us don't give injections at 1 month because we say, oh, this looks great, this looks normal, why do I want to re-inject? But then the disease is relentless, it's going to keep coming back. So monthly for 3 months. After that, at 8 weeks, that is at 16 months, 16 weeks or about 4 months, you do an assessment and you see if there is fluid, you re-inject. If not, you keep sort of the interval of about 3 months. And aflibercept, of course, was given every 2 monthly. So overall, if you look at the primary endpoint, which is that arrow, the dark arrow at 48 weeks, if you see aflibercept, according to the protocol, required 8 injections, while brolucizumab required 6 injections, and in the real world, we might actually come down even 1 more, right? So even in the clinical trial, the number of injections was 2 fewer, right? So we are talking about breaking barriers. So this is already, sort of incorporated into the clinical trial design. And so this was when you re-inject, right? So I think this is very useful for a clinical perspective in daily practice as well. So if patient loses one whole line of vision, so they were 612, now they became 618, you are going to re-inject. And the second thing is if the fluid is increasing, so they say more than 75 microns, but roughly it's about 10% fluid increment from the previous visit if there is, and if both are there, you definitely go and re-inject. And so this is sort of the matrix, and there's a lot of things happening there. But this is overall the treatment matrix which were used in this these clinical trials, and these are the consort diagrams where so the Hawk had about 1082 patients and the Harrier had about 743 patients. So this is the baseline characteristics, and without going into nitty-gritties, let me tell you that this was about most patients were white, and there were more women in this, and they were about 75, 76 years old. All these patients had a baseline vision of 618, had micro thickness of about 470 microns. All of them had subretinal as well as intraretinal fluid. So this is typically how an OCT in the clinical trial patients look like. So do you think your patients look like this? Now, most of our patients actually do look like this. Maybe they have slightly lower vision. So then all that the clinical trial says is what we can actually use in practice. So the primary endpoint, of course, was vision, and OCT were the secondary endpoints. So when you look at vision, they were very similar in terms of change in vision or improvement in vision. And how much did the vision improve? It improved about 1.5 line. So patient starts at 618. A lot of patients went to 6/12 parts. So if your patient actually is starting at 6/60 or 6/36, you should improve, expect patients to improve about 6/18 partially, and don't over expect and don't, sort of don't over promise. And so do all patients improve, and by how much? So if you look at 3-line improvement, that's a lot of improvement, a significant improvement. About a third of the patients improved to that level as well. When you look at OCTs, and Dr. Chronopoulos has also showed us this, what we really hate, or what the retina actually hates, is fluctuations. So if you look at the graph at the bottom, the one in green is aflibercept, and you can clearly see there's a lot of seesaw patterns, at least in neovascular AMD. And that is what is not good. So if aflibercept was lasting for 2 months, you would not have seen that kind of effect. So neovascular AMD, we are commonly seeing, most patients require repeat injections about 6 weeks right at the beginning. So that fluctuation is something that we don't want, and you can clearly see brolucizumab is giving us almost like a flat line. And coming to OCT, and we were discussing just now about which is better, which is not. So so this is if you see those black squares, they are where patients lost vision. So the one on the left is intraretinal fluid and intraretinal cysts. At 12 months, that is the third one, the first box on the left, the third graph. And it's very, very large. Almost 50% patients lose vision. The black is lost vision. So lose vision if there are intraretinal fluid and intraretinal cysts. So that clearly shows that intraretinal fluid is the biggest one. But neovascular AMD starts below the RPE. Fluid first goes into the subretinal fluid, and then it percolates into the intraretinal space. So obviously if there is fluid in the intraretinal space, it's the worst one. And if you look at the right, on the box on the right and the rightmost one, that is at 12 months, presence of PED or persistent, persistent PEDs or pigment epithelial detachments also indicate that vision is not going to improve as much. So a lot of patients actually continue to lose vision. So what we really want to do is entirely dry the intraretinal fluid. We want the PED to go down as much as possible. Maybe some amount of subretinal fluid is okay, and we could tolerate that. So, the Hawk and Harrier trials clearly showed that, fewer patients in brolucizumab had intraretinal fluid, and also fewer patients in brolucizumab have subretinal fluid. So the Harrier trial, some Indian patients were in this. About 17% patients had persistent SRF, whereas in the aflibercept group is almost double of that. And when you look at PED flattening, this is also what we want to have. Again, brolucizumab was able to flatten PEDs more than aflibercept. And the real idea or the barrier was too many injections. So how many patients are able to maintain one injection every 3 months? So it's about 56% in the Hawk and about 51% in the Harrier. So more than half patients are able to do well with once in 3 month injections. That's like 4 injections a year, which is like really good. We never had that before. And almost all of them will maintain this at 1 year. And again, almost all of them, that's 3/4, will maintain that at 2 years. That's actually, if you do your calculation, you will see that brolucizumab can do well with about 8 injections over 2-year periods. And aflibercept will need about 12 to 13 injections. So, that's a very large number of injections. So overall, so brolucizumab was non-inferior, at least in clinical trials. It was long-term maintaining vision better, and it was definitely better in controlling fluid. Let me quickly show you some of my cases. So this is a fundus photo of a lady with, so you can see the little bit of hemorrhage there, and this is how the photograph, the OCT looked like at baseline. As you can see, there is very minimal amount of fluid, but there is a membrane there. And in these cases, I generally choose ranibizumab as well. So monthly for ranibizumab, vision improved to 6/9. And then, this is typically how we do with ranibizumab, where we do treat and extend. So first repeat injection was given at 6 weeks, the second was given 8 weeks out, the third was given 10 weeks out. That's 2.5 months. However, she was scheduled for that 10-week injection, but she presented with drop in vision. And this is generally what you will have. When you're trying to extend, that 10-week is the biggest barrier. If you're able to extend beyond, you will be able to do well with that. So this is, that lake of fluid which has come back. And the whole question is, do you tolerate this? Or do you just say this is all right and I'll continue with the same drug, or do you shift? Right? So right at the beginning, saying I'm going to leave this alone is not okay. Right? So we need to do everything to dry it. And if it's not drying, then you say, okay, fine, I'll tolerate it. Right? So this is something that you don't want to tolerate. Right? So at 10 weeks, this is on extension. This patient has already taken 6 injections, 5 injections, including a loading dose. So she preferred ranibizumab again. She said, no, I don't want to do. After 1 month of ranibizumab, you can still see that fluid there. So again, do you tolerate this is the whole question. Not yet, right? I want to dry it more. So then you actually shift to brolucizumab.
You can finish in 1 minute.
Yeah, I will finish. I'll quickly show you. So you can actually don't tolerate this fluid. I'll show you one last case. So these are all you can quickly see they are improving with brolucizumab. Yeah, and this is a case who had bilateral AMD, which is not very common, and we can see how brolucizumab affects that. So this is the right eye of the patient on 2 different views, the horizontal and the vertical view. You can clearly see fluid there, and at 1 month, if you see, it's as if nothing was there, right? And then at 2 months, again, so this is a loading dose. After the loading dose, patient has done well, and at 6th month, he has started to get fluid back again. So the injection has lasted for 3 months, and he is doing well once in 3 months now. This is the other eye. Again, you can see, there is a membrane. There is intraretinal as well as subretinal fluid here. And on the right, this is 1 month post-injection, and 2 months and 3 months post-injection. And then, so he's relatively doing well. So these are after loading doses on the top right. And this is at 5 months. That is 2 months after the loading dose. He has gotten a recurrence. In the other eye, he had got it after 3 months, right? So what is the difference is in the right eye, there is not so much intraretinal fluid. In the left eye, there is much more intraretinal fluid. So at baseline, if there is a lot of intraretinal fluid, we could expect patients to do well every 2 monthly. But if not, if they don't have a lot of intraretinal fluid, they may do well once every 3 monthly. Whatever it is, the number of injections are definitely going to be lower. So, some information about brolucizumab.